Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chu Man Chu, and I'm joined by my friends Sam and Rachel. Hey guys.
Hey Chris.
Hello.
Our guest tonight is Dr. Vince Mukata to discuss eosinophilic esophagitis, or we like to say EOE, right? But first, Sam, do you want to remind us what our show is all about?
I'd love to. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
Tonight, we have a fantastic conversation with our guest, Dr. Mukata. He is a pediatric gastroenterologist at Cincinnati Children's. He has wandered the country for training. He went to Penn for undergrad, University of Cincinnati for medical school, go Bearcats, Brown for pediatrics residency, and Children's of Colorado for Peds GI fellowship. He has specialized in eosinophilic disease cure for almost 20 years, as well as in pediatric feeding disorders, and is currently the medical director for the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at Cincinnati Children's. He teaches us tonight about presentation, diagnosis, and treatment of EOE.
We should get into this episode. It'll be easy to take down. Swallow. Easy to swallow. I screwed it up. Oh, well, we'll keep it.
All right. And just so everyone knows, Dr. Mukata consults for Takeda, Regeneron, Sanofi, and Phaethon. All efforts have been made to present balanced information about treatment options.
Welcome back to the show. Dr. Vince Mukata, how are you doing?
I am doing well. Thanks for inviting me.
Because we're an informal group, is it okay if we call you by your first name?
Absolutely.
Excellent. So for our listening audience to get to know you a little better, can you describe yourself in a couple sentences and maybe add a little something that you do outside of medicine?
Sure. So I am a pediatric gastroenterologist at Cincinnati Children's. I specialize in eosinophilic esophagitis, and I wear some administrative hats as medical director for our division. I'm also a husband and father of 2 daughters and one extremely anxious dog who's wandering around behind me.
Rachel knows all about dogs right now.
You bet I do.
Just to put some context for the listeners, Rachel's brand new puppy, which will no longer be a brand new puppy by the time this episode comes out, may or may not have had an accident on her floor right now.
Yeah, like right in the background, and she is just hanging out. She's going to be an active audience, active listener tonight. So
perfect.
Awesome. Well, we like to start with some rapid fire questions just to get to know our guests a little bit better. One question that I like to ask is, what is the best piece of advice that you've ever received, whether it be as a learner, as a teacher, or really at any point in your career?
It came from our program secretary in residency, actually, who it's, I guess kind of a saying or whatever, but her mantra in life is always like everything happens for a reason. And, I think as a residency program secretary, she sees, residents coming in at all times, all hours, all emotional states. And that was kind of her way of saying like, it's going to be okay. I know you think that this is the end of the world. You didn't get into fellowship, you didn't, whatever it might be, but things, one door opens, one door closes, another one opens. So be open to what is coming next, and just have faith in the process and keep working. Because I think if I look at my kind of career path, it's been a series of zigs and zags that got me to the place I'm at. I can't imagine doing anything else. But I went into all of this not wanting to be a doctor. Then I'd never thought about being a pediatrician, had never thought about doing GI until a moonlighting attending convinced me to do GI, to do a month on Peds GI as a med student. And then I thought I was going to be a transplant hepatologist, and started in a transplant hepatology lab until my research mentor left. And so I'd scrambled into an eosinophilic disease lab that was just starting in Denver where I was, and that's how I ended up doing all the things I'm doing now. So, I think the lots of things may seem off topic, off kilter, and you never know how it's going to come back and affect you. And even including just a random research project I did at the very end of my fellowship. When I went to my first job, they said, "Oh, we need somebody to do feeding team. You've published a paper about feeding. Why don't you do that?" And then 20 years later, I'm still doing feeding team now in a different institution. So.
And I think what's so challenging for all of us in medicine, right, is we're all very type A. We all want to have this plan where it's like, okay, we do this and then this and then this, and this has all been set out ahead of us. But it turns out, it sounds like that no matter what you end up doing, it's all going to work out for a reason, and we can all appreciate some of that advice, I think.
Also, as 3 med-peds people here, I don't know if Chris and Sam, you can identify with this as well, but I know that I am very indecisive when it comes to what I want to be when I grow up. And so I have tried to say yes to a lot of things. And I think what your advice, Vince, what it kind of highlights is just saying yes. You never know what is going to stick. So I love that advice.
Yeah, to share just a little personal anecdote of how I ended up here. Not that anyone really asked, but I found out probably second year of medical school, maybe even first, second year of medical school, that med-peds existed. And so I was very excited to do that. And that was as far as I knew that I wanted to go. Everything else since that, I've had no idea. I was like, okay, I want to be a med-peds resident. And then that's been it. So here we are doing podcasts and taking care of patients throughout the spectrum. So thank you. Okay, we've gotten really off topic here. We do want to talk about EOE at some point. So Rachel, we should probably jump into the case, and I don't think I'll be asking any more questions off the bat.
Okay, let's do it. Let's dive right in.
Whether this is your first episode or you've been with us since day one, you know our goal has always been to share clinical pearls and practice-changing knowledge about core topics in pediatric medicine. So let's talk about something that actually changed my day-to-day as a pediatric hospitalist: FIGS. I can't walk into a clinic or hospital without seeing people in FIGS scrubs, and I get it. I wear them too. They're incredibly soft, form-fitting, and durable. And it's not just us. If you've been watching a certain popular emergency room drama on TV, maybe based in Pennsylvania, yep, they're in FIGS too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids, and kids come with messes, I love that FIGS are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine over 50 times and they still look brand new. Now, with the holidays right around the corner, it's a perfect time to treat yourself to some fresh looks for the new year. Which is great because FIGS just dropped a ton of new limited edition colors and styles for this season. And so Cribsiders listeners, if you want to check them out, FIGS is offering 15% off your first purchase at wearfigs.com with the code FIGSRX. That's wearfigs.com, code FIGSRX.
So this is a case from Cashlike Children's. Ahmed is a 10-year-old boy who presents to your clinic with a several-month history of reported difficulty swallowing. His parents tell you that he previously was not a picky eater, but he now avoids many of his favorite foods and takes a long time to finish his meals. Ahmed has a history of allergic rhinitis and atopic dermatitis, but is otherwise healthy and doesn't take any regular medications. So just to kind of start off the bat with a question, Vince, could you start with describing how you would evaluate a child like Ahmed and what differentials you might be considering in this case?
So I think the biggest thing here for me would be getting a little bit more history. And I think obviously based on the podcast and based on what I do, anytime we hear feeding difficulties with atopic diseases, so, in his case, I think he had rhinitis and maybe some eczema, or if we hear food allergies or asthma, we jump right ahead to it must be eosinophilic esophagitis. And I think we have to take a step back and say, well, all we know is that he's become a picky eater. And so that's important point one, right, is that he was a normal eater, at least to the family's thoughts, and then something changed. And so first questions are, what might have changed around that time. Was he sick? Did he have something else that came up? Did they notice any other changes? Have there been developmentally? Has there been any regression? Are we starting to see some other bigger process happening? Is this a more global problem, or is this just everything else is the same and he just has become picky? Once you get through that, then it's, well, talk to me about what meal times look like. Describe a meal to me. Tell me what it used to look like. Tell me what it looks like now. Is he complaining about anything in particular? So for us, if someone says, oh, it hurts when I eat, that's very different than, well, he used to eat, he used to eat these foods and now he's down to these 3 foods, and it has to be labeled in a very specific way. That's a different kind of problem. We're worrying about pain or dinophagia versus someone who says, oh, he's choking, he's coughing, he seems to have a preference for particular textures of foods, he's happy to drink but not to eat. All of those things would be subtle tells for us to say, well, maybe he is having more trouble swallowing. The one thing that we try never to ask, especially a child, but even the family, is, are they having difficulty swallowing? Or worse yet, are they having dysphagia? Because no one knows what that means, right? So I like the idea of asking, like, describe to me what a mealtime looks like. Tell me what it looks like when he chews food. If he's having problems with regurgitation, those kind of things, is the food going down and coming back up later? Is it coming back up immediately? Is he spitting it out before he ever swallows it? All of those kind of questions become very important.
As you're getting some of this history, you also mentioned that, at least in our case, Ahmed's got like allergic rhinitis, atopic dermatitis. Does that history often give you put a higher in your differential that could be EOE? And the other question is, does lack of that put it lower on your differential EOE? And then I apologize for making this a compound question, but what about family histories? Like, what if the patient doesn't have much history, but we have a first-degree relative, a SIB, or a parent that does have a lot of atopy?
So any atopic history does increase our risk of having eosinophilic esophagitis. So it makes us think about it more. And the more atopic the patient is, the more conditions they have, I think the more we think about it. And we will go back to asking about, other things in the history that we think about are, was he a refluxy baby? That is he that child who had reflux as a baby who, quote unquote, never grew out of it and has always been my child that is more of a puker? Everything that affects everybody in the family, he's the one that's throwing up all the time. A lack of atopic history doesn't rule out eosinophilic esophagitis, but it certainly puts it a little bit less likely and less to the front of the mind. That family history question is also interesting. So certainly a family history of eosinophilic disease increases the risk in any relative. The one question that we always like to ask is, is there a family history of eosinophilic disease or eosinophilic esophagitis? Another question is there someone else in the family who's had trouble swallowing? Has anyone in the family had their, quote unquote, their throat stretched? Because that's usually that you'd be surprised how many people say, oh yeah, well, grandma and grandpa, they've all had their throat stretched multiple times. But no one ever told us why, or they just said it was just reflux. And sometimes it might be reflux, but it is not uncommon for us to diagnose a child and then the family to say, "Oh, wait, hang on, Dad chokes every time he eats. Maybe he should get evaluated," or maybe that explains why Grandma was the way she was. So it is a disease that has familial predisposition. It's not a simple monogenic disease where it definitely is multiple genes and different families. But we do know that it runs in families and that the risk increases.
And I actually think we've been kind of teasing this a little bit. I think we should probably talk about what are the clinical features in the presentation of EOE. Then we can kind of come back and put our differential and then make our diagnosis, if that makes sense. Would you mind walking us through kind of what is the classical presentation of EOE then?
Yeah, so the classical presentation of eosinophilic esophagitis changes in some ways as you get older, and so there's actually one of the original papers about this is a letter from 2004 in the New England Journal, and that there's a diagram in there that shows it really beautifully that in infants and young toddlers, the symptoms tend to be nonspecific. So reflux that doesn't respond to reflux medications, feeding difficulties. And so the classic thing there is it's a child who is happy to breastfeed or drink. And usually they do well on very thin purees. And then as soon as they get to, the stage 2 baby foods where there's solid material, they just start pushing that away and they'll drink, but all solid foods become dangerous to them and they kind of stay away from it. As you get more towards that school age child, then it becomes maybe the picky eater, that they eats, little Ahmed or Jimmy is always been picky. He only likes certain things. And frequently we pick up later on that those things tend to be softer texture foods. He just quote unquote doesn't like steak or chicken breast or pork chops. But he's fine with ground meat or soft textured things. But then, in those age ranges, it tends to be belly pain, nausea, vomiting sometimes. As you get older into adolescence, and then as in folks who present in adulthood, it becomes more true dysphagia. And part of that is probably just the language skills to express it. Certainly some of those babies with feeding intolerance may have dysphagia and just not be able to tell you. But adolescents and adults will present with dysphagia, and in the worst case, true food impaction, where food gets stuck and needs to be removed.
So how common is a diagnosis of EOE? And does the distribution vary, or do you see a distribution that peaks at certain points? Is it bimodal, trimodal? What does that look like?
So I think it's still still the largest group. The highest incidence is still in young adults. But if you look at it across pediatrics, we see it very commonly in the adolescent patients. But I think what's been an interesting shift over the time that I've been doing this is, if you'd asked me 15 years ago, what does a patient with EOE look like? I would have said, it's a 15-year-old boy who comes in the middle of the night with steak stuck in their throat. And then we take the steak out and their esophagus looks terrible. And lo and behold, that's what they have. What we have realized through looking at feeding and some of these other things is we can pick up on these patients much earlier. And so I think if you asked someone training right now what a typical EOE patient looks like, they'd still say, oh, sometimes it's that 15-year-old boy, but a lot of times it's the infant with feeding problems. It's the reflux that doesn't get better. And we think that by catching those patients early and treating them, we're preventing them from ever becoming that 15-year-old boy with steak stuck in their throat.
So it sounds like the way you describe it, because, didn't you say that it was first discussed in a letter in 2004? Does that mean this is a fairly newish diagnosis, like in the last 20, 25 years then?
Yeah, so it's a relatively new diagnosis. So it has been described before that, actually. So there are actually case reports in adult patients actually with achalasia back to the 70s, like 1977. But it's interesting because this has evolved. There's a famous in GI circles paper from 1982 that talks about literally the title of the paper is Eosinophils in the Esophagus, a new criterion for reflux esophagitis. And so that was kind of the dogma. You see eosinophils in the esophagus when you biopsy, and that equals reflux. And that was kind of the way we thought about it till the early 90s, when a few astute people said, we've been treating some of these patients with reflux treatments for years, and they just don't get better. There's something else going on here. And a GI doc from Johns Hopkins said, well, maybe there's some allergic condition associated with this. Put these patients on elemental formula, and lo and behold, their esophagitis got better. And that's where we kind of first started saying, well, there's something else here. There's an allergic component to this, or this is an allergically driven disease. Our center here in Cincinnati started in 1999. CHOP is about the same time. There's several centers all starting about the same time with investigations into this disease, what's become eosinophilic esophagitis. And it's an interesting disease in that it really was described first in pediatrics, and then the adult world came to believe that this disease existed in adults as well. Because for a long time there's a lot of debate back and forth. Is this just reflux by another name? Is there something? Is it truly a different disease or not? And that's been really over the last 10 to 15 years, the adult GI docs and allergists have also really jumped on board and advanced the field on the adult side.
And I just wanted to get back to a little bit of the clinical features. I wanted to clarify one thing, and that was the odynophagia that we were talking about, right? So we know, and we're going to get into the diagnosis and endoscopy in a second, but clearly this is a problem with your esophagus. It's eosinophilic esophagitis, and we talk about itis it being a piece. And we talked about belly pain and whatnot. Is there actual odynophagia that comes with this, or are we mostly looking at dysphagia? And I just want to be able to separate that a little bit, so when we talk about differential diagnosis, that could be helpful.
No, it's a great question. So some patients will describe some degree of odynophagia, although it's usually in the context of food getting stuck, that they can feel it going down. And, as you know, kids' description of pain can be a little bit nonspecific. And so is that discomfort? But patients will describe if food is getting stuck, that can be painful. But if someone says, hey, every time I swallow anything, I'm getting searing pain, back to our differential question, that makes me think more about infectious esophagitis or caustic. Something like herpes esophagitis or candidal esophagitis can certainly present more with odynophagia. Or a caustic or those kind of things. It's not that common for patients to come in and say, oh, it hurts like a knife when I swallow, and it to be EOE.
Gotcha. So let's go back to Ahmed. And I know we didn't give you that much detail on the case, so apologies for that. Let's just say that he has, that he's just saying he's picky, saying it's not hurting, he just doesn't really like this food. And let's just presume that he's just not really explaining food impaction to us. Nevertheless, I was hoping you could walk us through, just from a differential diagnosis, okay, I'm thinking about these things, what's on my differential, and then how am I going to actually make that diagnosis?
Yeah. So I think in some of this, and we're going to talk about this a lot tonight, is kind of the idea of shared decision making, right? And so if I'm coming into this with a high degree of suspicion that this might be eosinophilic esophagitis, then the way to make the diagnosis is to do an invasive test and to do an endoscopy. If either I'm hedging about it, I'm not quite sure, and maybe or the family says that sounds very aggressive, I don't think I really want to go down that road. It's not unreasonable to say, okay, if your presentation is really picky eating, is it worth doing some feeding therapy? See how you do. If things get better, then maybe we just stay hands off and watch and see how you do. We'll set kind of a time limit. Let's give it 3 months or 6 months. You're going to come back and see us, a lot of times in the context of our feeding team. I'll see you again then. If we're still having these same questions and we still don't understand, let's agree now that that's the next step. So that's kind of the diagnostic pathway to a certain degree. If someone comes in and says, I think he's choking, or I think he's having trouble swallowing, or he's coughing and spluttering, if I'm worried about things like, is he aspirating, then certainly having him have a clinical evaluation by a speech pathologist with feeding skills, thinking about doing something like what we call a video swallow here in Cincinnati, but other places call a modified barium swallow, or a FEES exam, a fiber optic endoscopic examination of swallowing, something to look to make sure that there's no aspiration would make some sense. If there's a concern about could there be narrowing of the esophagus, but the family doesn't want to necessarily start with an endoscopy, an esophagram, or again, we call it an esophagram here. Other places call it just a straight barium swallow, would be a way to look for anatomic narrowing or as a gross screen for motility issues. So there's lots of different ways to approach this, and it really depends on what that story is and how the family is feeling about how they want to approach it.
So that leads me to my next question, because you said that shared decision making is really important, how to plan this out. How do you describe what EOE is to a parent? Because that obviously you have to sort of explain a little bit to them. I'm sort of interested to see how you would explain it to the parents to maybe help us when we're trying to do that discussion with our parents too.
So I usually tell families that this is a chronic disease. So it is not a disease at the moment that we have a cure for, but it is very treatable. That it involves inflammation of the esophagus, and inflammation meaning you have white blood cells in the esophagus called eosinophils that are not supposed to be there. This particular type of white cells is typically associated with allergies. They can do some other things in the body, like fighting off parasites. We don't think that this is driven by parasites. That this is typically driven by food allergens, but it's important to say that it is not I eat a peanut and I anaphylax type of allergy. It's not an immediate reaction by and large. And so which brings us to, it's not something that we can diagnose what the foods are by doing allergy tests. That's a different type of allergy that we're looking for there. And so we will tell families, look, it is typically driven by a food, but it can be very difficult to figure out what that food actually is. The other thing that I usually tell people off the bat is you may not know what food it is based on symptoms. So you may think that, it's chicken that's doing it because every time he eats chicken, he chokes. And I will probably tell you it's possible it's chicken. It does happen. But it's more likely that it's something that's in his diet all the time, with the most likely thing being dairy, that he doesn't have an obvious reaction to, that it's the chronic exposure to the food that leads to inflammation of the esophagus, which eventually then leads to the symptoms that you're seeing. And so it's again, that's a lot of concepts to go over. And so this is something we have to kind of go through piece by piece. And I think your question and the way you framed it as, tell me how you explain it to families, and then how you talk about that leads you directly into how do we talk about treatment? How do we talk about long-term course? And you have to kind of keep coming back to that and say, this is why we said this is a chronic disease. This is why we said there's not an allergy test for it. Because, everybody, you get a diagnosis and to a certain degree, your brain stops working until you get a chance to process. So they're not hearing all of that very detailed answer that I just gave you.
I think that was a good actually discussion in pathophysiology and broken down for ways that we can all understand it, whether you're a parent or also a physician, just to talk about, hey, there could be a chronic exposure that's causing an allergic response that is causing inflammation of your esophagus that is then causing some of these symptoms. Let's talk a little bit before we discuss the treatment, which is going to include how we address these allergens. But before we do that, I did just want to complete this thought with the actual diagnosis itself. So say we say, you know what, Ahmed is, doing these things, but parents are like, I definitely want an endoscopy. Like, let's do the gold standard test. Can you walk us through how we go about doing it, what entails with the endoscopy, what's our diagnosis, and how do you officially make that diagnosis once they're done with the procedure?
Sure. So in order to look for eosinophilic esophagitis, our typical test is to do an upper endoscopy. In most places, that is done under anesthesia. So we do tell families this is going to be, general. He's fully asleep anesthesia. It's a very short procedure, so it's a quick nap, but usually about a 15-minute sleep time, 5 to 10-minute procedure, outpatient procedure, and going home. But, from a family's perspective, I kind of tell them, look, what we do is we put a flexible tube that looks a lot like my finger. It goes down the mouth, swallowing tube. So it looks in the esophagus, looks in the stomach, looks in the first part of the small intestine. We turn the camera on, we take some pictures, and we take biopsies. And I always am getting better about reminding myself to tell families, when I say biopsy, that is how we look for inflammation and for infection. It doesn't mean we're looking for cancer, because I think a lot of people hear biopsy and that's where they go immediately. So it lets us look for all of those things. Those biopsies we look at under the microscope, and we look for signs of inflammation. So that's the basics of endoscopy. I'll just put a little caveat in there, because we're getting more and more families coming and asking us about unsedated endoscopy, where we're able to do transnasal scopes. Several centers are able to do transnasal scopes. We do them here as well, where we can do it unsedated in the office, using a scope that goes through the nose. I typically don't recommend that as my initial scope, just because it's a much smaller endoscope, and we don't always go as deeply with that, so we don't always get to the small bowel. So for your first scope, I would tend to prefer a full diagnostic upper endoscopy.
So when you're doing the scope, is it standardized how many biopsies you get at like different levels of the esophagus? And then are there like specific visual things that you're looking for that you're like, oh, I really need to biopsy that portion because that looks like it could be very distinctive of EOE on visual inspection or something?
Yep. So to the question, what do we look for? So visually, so the first thing I would say is there's literature out there that would say that anywhere from 10 to 30% of patients with eosinophilic esophagitis can have pretty normal appearing esophagus visually. And so that comes back to our recommendation that you need to biopsy regardless of how it looks. Obviously, you do biopsy in areas that look diseased. What do we look for? So the acronym or the scoring system that has been published is something called the EREF score, and so it stands for edema. So you're looking to see, normally when you go down the esophagus, you can see in the wall of the esophagus little blood vessels very crisply, and when you have edema there, that those blood vessels get kind of blunted looking. It's hard to actually see them. Or sometimes you don't see them at all. And that suggests that the esophagus is sort of swollen and you lose those visual cues. R is for rings. So the esophagus should be kind of a smooth pipe-like appearance. And if you see rings, circumferential rings going down the esophagus, that's usually a sign of some fibrosis or remodeling of the esophagus. It's usually a little more advanced disease. Exudates are little white spots. Typically, there's a characteristic appearance of these little white pinpoint spots throughout the esophagus. And those actually, if you biopsy them, they correlate with clusters of eosinophils coming to the surface. And so they're eosinophilic microabscesses on histology. And then furrows or lines. So we talked about rings that are circumferential, and then there's lines going down the esophagus that almost look like train tracks. And those can have some depth to them. And again, we think of that as being kind of, it's edematous, or the tissue sort of folding on itself. You're seeing some remodeling changes there. And then the S in it is stricture. And so, hopefully we don't see a stricture. It tends to be a much more advanced disease thing. And we'll talk about that more with natural history. There's a few other things. So there's nothing that's pathognomonic. So you can see some of these changes, but if you see all of those things, most of us would say, yeah, this is EOE. There's another thing that's quite alarming that's not in that scoring system that's called crepe paper esophagus, which is this phenomenon where the lining of the tissue is very, very friable. And just by passing the scope, or I've had it happen even with, I just put air in, and just as the esophagus is opening up, you literally see a line, a rent opening in the wall of the esophagus. And it looks terrible, and it's very alarming because it bleeds. Typically, though, it's a very superficial appearance, but it's just that tissue seems to be very kind of stiff and fibrotic, and it doesn't tolerate distension very well. And so that's not something we typically see in anything else. So if you do see that, odds are it's EOE. So those are the typical findings. I'm trying to remember back to your original question if I hit all the parts of that.
Yeah, and then the last piece also is the histology. So what do we get from the biopsy that our pathologist reads that gives us our diagnosis?
Right, and I think you did ask the question about, do we do standard placement of our biopsies? And so it is a patchy disease. So people have actually done studies where they took biopsies in different locations at very kind of stratified areas, and to say, how many biopsies do you need to feel like confident that you have 100% certainty of catching EOE if it exists. So we typically say you need to do 5 biopsies or more from the esophagus, typically at least at the bottom of the esophagus and at the top of the esophagus. So distal and proximal esophagus. A lot of us will sample in the middle of the esophagus as well. Just, we may not separate it out in the jar. But you definitely want to get a representative sampling of multiple spots. One of the thoughts there is, if you see inflammation only at the bottom of the esophagus and not at the top, it's perhaps more likely to be reflux than it is EOE. It doesn't always hold up, but that's a way of thinking about it. So the other thing is, as I said, we also look in the stomach and small bowel. So we tend to do a couple of spots in the small bowel, so distal small bowel, and then in the first part of the duodenum, a couple of spots at the end of the stomach or the antrum, and then in the main body of the stomach, and then again a couple spots in the esophagus. As far as what we look for, so we haven't yet said the magic number. So the consensus guidelines, the diagnostic threshold for eosinophils is 15 eosinophils per high power field, meaning I look through the microscope, I don't, at 400 powers magnification, I don't move it around, I count the number of intraepithelial eosinophils I see. If there's 15 or more, that's enough to make the diagnosis of EOE. My partner here in Cincinnati, Phil Putnam, who's been doing this longer than almost anyone, is famous for saying this is a disease with eosinophils, not a disease of eosinophils. Yeah, so his point there is really, it's not just the eosinophils. Reflux can cause eosinophils. You can see eosinophils in the esophagus in Crohn's disease. Other things can do this. It has to be in the right context. All the symptoms that we talked about, the endoscopic appearance, all of those things together. We also look for other features in the esophagus. Again, one of my colleagues here in Cincinnati, Margaret Collins, who's a pathologist extraordinaire and has written all the papers on pathology in EOE. She has come up with a scoring system that incorporates some of the other things that we look for. So things like, are we seeing dilated intracellular spaces? So kind of that edema piece. Are you seeing space between the cells themselves? Are you seeing how thick is the wall getting, which kind of correlates with the idea of, are you seeing fibrosis develop? Are you seeing stiffening? And again, we're trying to correlate what we see through the microscope with what we see on histology. So there's a number of other features that are also very important as we look at all of this. And we do try to tell families, because, they see the pathology reports. 15 eosinophils is the number. It is very true, but we try not to just hang our hat on that. And it's not as simple as saying, this scope you had 30 eosinophils and the one before you had 15, so it must be twice as bad. It's definitely not that simple.
That kind of goes into my clarifying question. How many of the biopsies need to be positive? Like, I don't know how often this happens, but what if a patient had only one biopsy out of 20 that had greater than 15 eosinophils per high power field?
So it's a great question. It's easier it's easier for me to feel confident in the diagnosis the more widespread the disease is. And so your point is well taken. So if I have had families, and we've all had families where you'd say, I do understand the biopsy report says there's a peak count of 70 this time, and last time the peak count was 20. But I can tell you, based on the report and based on looking at the slides, last time it was 20 eosinophils everywhere I looked in the esophagus. And this time, 99% of it looked fine, and there was one spot that just had a lot of eosinophils. I'm much less worried about that patient. In fact, if everything looks normal and they're feeling fine, I would probably say, you're probably in remission. I don't quite know why that one spot is weird, but let's just keep going the way we're going. Versus you had, 50 last time and now you have 20, but you still have 20 everywhere and it still looks abnormal. That's not good enough.
And say I was the primary care doctor that saw this patient before I referred him to you. I kind of went through the feeding pieces and I, did a little speech and it sounds refluxy. I put him on a PPI beforehand. I sent them to you. How is that going to change, if at all, the what you're going to find on endoscopy?
Yeah. So that is a great question. So the gold standard now to do the endoscopy is to take people off of PPIs for at least, let's say, 6 to 8 weeks. Ideally, we want them off of it for a while because PPIs take a while to kick in, and it does take a while to get out of your system. So we really want it completely out of your system if we can. The reason for that is we used to actually use this as a diagnostic criteria. You put somebody on a PPI and then you do the scope with the idea that if you still see eosinophils there, then it must be more than just reflux, quote unquote. What we have realized is there's about 30% of patients with eosinophilic esophagitis by any other definition, visual appearance, gene changes, whatever you look at, it is EOE, but who still respond to to PPIs, to the acid blocking medicines. What we've realized now is there's some anti-inflammatory effects of the PPIs independent of their acid suppressing mechanism that do treat the EOE in a directly anti-eosinophil way. And that works in about 25 to 30% of patients. And so the thought was, well, if we, and this is a subject of a very long process of discussion in 2018, and the end result was us kind of coming to consensus and saying, by pre-treating with PPI, we may be systematically missing or undercounting by 25 to 30% of these patients that truly have a disease that we've just treated. And so we try to take people off. If someone says, I can't come off my PPI because as soon as I do, I am absolutely miserable, but I'm also miserable on the PPI, I'm much more likely to say, okay, it's probably fine because you're still symptomatic. So let's go ahead and look. But if it's normal, quote, then I may have to kind of say, well, let's really think about this and try to get you off the PPI and see what happens. So ideally off PPI.
I have one last quick question before I give a clinical update. Would there be any, say a patient is on Pepcid or famotidine instead of a PPI, maybe this isn't seen that often clinically, but would that have a similar role as PPIs?
It's a good question. Less likely than the PPIs, and it's certainly less likely than the PPIs. So we have sometimes, and I think a lot of us have sometimes compromised on that. On patients who come in and say, "I'm just miserable. Can I please have something?" We'll sometimes say, "Let's try the H2 blockers. They're much less likely to cause masking, so to speak, of the EOE, and see if we can give you some symptomatic relief until we do the scope." Ideally nothing, but if you have to pick, I would definitely do a Pepcid.
Okay, that's helpful. Thank you.
Hey, Cribsiders listeners, are you a pediatrician ready to focus on what matters most, your patients? Well, the Permanente Medical Group in Northern California is seeking pediatric physicians to join their multidisciplinary practice, serving families across 21 medical centers with an 80-year legacy of excellence. So here's what sets them apart. No RVUs, no billing headaches, no practice overhead, just you providing exceptional care in a physician-led, mission-driven environment. They offer flexible schedules, a competitive salary and benefits package, moving and relocation assistance, and Northern California home buying assistance. Plus, they are PSLF eligible. Whether you're drawn to Northern California's natural beauty, year-round recreational amenities, or vibrant communities, they have locations you'll love to call home. Visit northerncalifornia.permanente.org to learn how you can help them fulfill the promise of medicine at Kaiser Permanente, Northern California. Again, that's northerncalifornia.permanente.org.
All right, so just for a clinical update, pulling us back to our case, Ahmed undergoes endoscopy, which reveals multiple rings in the proximal esophagus, and the results from several esophageal biopsy specimens show greater than 15 eosinophils per high power field. So based on the conversation that we just had, Ahmed does meet criteria for EOE. I would imagine that one of the first questions that parents ask you once you tell them that their child has a diagnosis of EOE is, what are the treatment options? What are the next steps? Would you be able to kind of walk us through the framework for treatment options?
Yeah, and this comes kind of back to the idea of shared decision-making, because it really is a discussion. And I always lead with, there's not one true way to treat this disease. There's what works for you and your family today, which can change, right? So you're not committed to this for your lifetime. You can make a change in kind of treatment decisions. Your child may come back to you later on and say, actually, I don't want to do this anymore. And that's okay. We can change usually with success. So the first line treatment options are typically, we offer PPI as a treatment, and the recommendation is high dose PPI, and there's a little bit of a debate back and forth about what that means and whether you treat with twice a day dosing or not. I will be honest with you, because we have more options now, and this is where we go off of into more my way of practicing than guidelines or evidence-based practice. I will typically not. We used to use twice a day high doses of PPIs as our test, and sometimes as our treatment. So, kids on 30 milligrams of lansoprazole twice a day, or 40 milligrams of omeprazole twice a day. Now that we have more treatment options, I'm less likely to want to do that, just because of, there are some concerns about long-term use of PPI, and we are talking about a chronic disease that requires long-term use. So in the grand scheme of things, if it's once a day dosing, I'm okay with it. I try not to keep people on twice a day dosing if I can help it. So PPIs work in about let's say 25 to 30% of patients. So that's certainly one option. It's the families. Some families feel very good about that it's an oral medication. Lots of people in their family may have been on them. They feel pretty comfortable with them. So I think that's certainly a option. Another option is dietary elimination. And so we started to talk about this earlier. We used to do allergy tests on all these patients and do huge panels of allergy tests and then eliminate the foods. And then we realized that we would have lots of false positives. So foods that patients were tolerating that they tested positive for, we would take it out of their diet and their esophagus didn't change. And now potentially we've actually exposed them to the risk of having an actual food reaction when they reintroduce the food. We had lots of foods that tested negative that you take it out of their diet and their esophagus gets better. And so with experience, we kind of came up with these are the 6 or 8 or 10 most common foods. And so that we do variations on empiric elimination diets frequently with those. So dairy or milk products or all mammalian dairy is number 1 on the list. Roughly speaking, about 50% of kids will have dairy as one of their trigger foods. So one diet option is to say, we're just going to eliminate dairy. And that works in about, again, 30 to 40% of patients based on the studies. As I said, some of that 50% of kids that react to dairy also react to another food. So if you just get rid of the milk, it may not be enough. So that's why there's a discrepancy in those numbers. One option is to do a step-up approach where you start with, I'm going to take away 2 foods at a time. And if that doesn't work, I'm going to add another 2 foods. And then if that doesn't work, I add another 2 foods. Usually the 2 foods are dairy and wheat or dairy and egg. So dairy is a trigger in about 50% of patients. Wheat and egg, roughly speaking, are about 25% each. Soy is the next one at about 20%. And then it goes down to peanuts and tree nuts are probably 5 to 10%. Fish and shellfish is a little bit less than that. I think we are seeing more and more kids who react to corn and legumes now. I think especially as there's more and more pea protein products that are out there, we're seeing those patients who react to those things. Higher protein foods tend to be more likely to cause this, but meats are probably in the 1 to 2% range. But so the classic elimination diet that we all used to use is something called a 6-food elimination diet, which is milk, soy, wheat, egg, fish and shellfish, peanuts and tree nuts. That works in about 70% of patients to put people into remission. And then typically what you do is you add foods back one at a time. With the thought that most people will, if not all 6 foods. And so that's a painstaking process, right? So you're adding foods back in, and our recommendation is generally before you add the next food, if you don't have symptoms, you add a food, you don't have symptoms, after a period of time, we usually do 3 months, we repeat a scope and say, it's still fine. Because the worst thing that could happen is you have a lag, you don't get symptoms, you get to something like milk that's really important to your diet and you do the scope and it's bad. And now you don't know, was it peanuts that you don't really care about, or is it the milk that really is upsetting to the child to lose again? So when we talk about diet, I usually tell families like, this is a way that we can try to be medication free, but it is painstaking and time consuming and requires a lot of endoscopy upfront. But hopefully it gets you to a stable long-term place. And as I said, there's all sorts of variations on how you approach that. The ultimate thing that patients will still see is going to elemental diet. So nothing else is working, or I really want to do diet. I don't want to do anything. I don't want to do medications. An elemental diet where you put somebody on one of the elemental formulas, the amino acid-based formulas only, that will put the esophagus in remission in upwards of 90% of patients. So I always tell patients, like, that's probably the most effective treatment for here to here, for your esophagus. Whether that's the most effective treatment for your child, that's a little bit more open to debate. I think for some patients, they do great with it. Others, they don't. There's a really important kind of logical thing to talk about there. So when you do put somebody on an elemental formula only, most kids, babies are fine. They'll do it. They don't know any better. Older kids, and especially because you have to start taking more and more volume to meet your nutrition needs, they tire out pretty quickly. Elemental formulas are not a taste treat for most of the time, and it is a monotonous diet. And so you do frequently need to talk about, do we need to do things like a G-tube eventually? And so I tell families, look, I know you're going to Google it. It's fine, but just understand you're going to find things about G-tubes, and it's going to seem like there's a straight line from EOE diagnosis to G-tube. And that's not true now. It's even less true now. It was never fully true, but yes, some of our patients have G-tubes. It's by far not the majority. I say all this because it is still out there in the internet. I tell families, look, the people that are posting on the internet are the ones that have the most severe disease. They are looking for help. And so they're going to be the ones that are going to be posting the most extreme cases. You know people with this disease and you have no idea because they're doing just great. And that's what we want. If you do elemental diet, the very important thing is, if I take away a defined group of foods, I take away 2 foods, 8 foods, 100 foods, but I tell you, you know exactly what I took away, and your disease goes into remission. If I add those foods back, it may take forever, but if I add those foods back, I will be able to tell you these are your trigger foods, right? Because it's a kind of logical. I add it back in. Is it bad or not? If I take away everything, if I put you on elemental formula, I'm never going to be able to tell you with 100% certainty that these are your trigger foods. All I can tell you is this is a diet that you tolerate, right? Because there's an infinite number of foods. There's some caveats, like if you get somebody, you put them in remission and elemental, and then you put them on a 6-food elimination diet and they're still good, then life is good. You're going to be able to do a traditional 6-food approach from there. But it's an important philosophical distinction, and it's important that families understand that before they commit to that diet, because you are talking about the real potential for G-tube. So before we create any additional holes, we need to be very straightforward about that reasoning. So this always feels like a painfully detailed discussion, but it's really important, because that can be a tragic discussion after the fact for somebody who has had a G-tube and said, but I did this because I wanted to know what my triggers are. And we kind of have to say, that's not what we can do for you.
So, I mean, you were saying that we do this even less nowadays because I assume we have other treatment modalities. I mean, I remember when I was a resident rotating through an EOE clinic, and they were doing all sorts of weird things, like opening up like the budesonide nebs to swallow topically and things like that. Can you talk about topical corticosteroids and where this plays into it?
Yeah. So topical corticosteroids is sort of the third first line option. And sometimes we have to use combinations of these things, or we will offer combinations of these things to families depending on what they want to do. But typically we'll start with one thing at a time. So swallow topical corticosteroids. So we are using medications that are typically used for asthma, but using them to basically apply them to the esophagus. And so, to your point, the typical things that you do are using an inhaled form of steroid. And so you can either use a kind of classic aerosol HFA type of inhaler. It's important to say we actually have to use that type. So the newer breath activated powder forms of inhaler steroids don't actually work very well, because the way that you get them to work is you inhale, right? And so it's going directly into your lungs. We want it to go to your esophagus. So you need to we're actually teaching people to take their inhaler exactly the wrong way. So the way you don't want them to do it for their asthma, so you have them spray at the back of their throat, swallow, spray, for however many sprays you need, depending on the dose. And you swallow, and then you tell them don't eat or drink for 30 minutes afterwards, because it's a topical treatment, so you don't get much systemic absorption because of very high first pass metabolism in these drugs. So the typical ones are either fluticasone or budesonide. Both have high first pass metabolism, so we don't see nearly the amount of systemic side effects or systemic absorption that you would with something like prednisone. But you need to deliver it to the esophagus. So either the inhaler that you swallow, or the typical way of doing budesonide is exactly what you described. It is you take the nebulizer packet of medication and you mix it with something to make it thicker, a little bit more palatable, and a little bit stickier, so to speak, and you swallow it. Same thing, nothing to eat or drink for 30 minutes afterwards. Typically, the steroids are given twice a day. Lots of little caveats to that. So I don't like using the inhaler in kids less than approximately the age of 7 because it's very hard for them to keep it in. It shoots out of their mouth or shoots out of their nose. In my kids who have really bad asthma and need frequent use of rescue inhalers, I'm really reluctant to use an inhaler because as I said, I'm telling you to take it exactly the wrong way. And that'd be hard enough for me to remember, oh, wait, this is my controller inhaler that I need to inhale. This is my rescue inhaler that I need to inhale, and this is my EOE inhaler that I need to swallow. So if I have to do it, I literally tell families, I really want you to put a piece of red tape or something that everybody knows. Red tape is the emergency one for the albuterol. And I even made people, I want to see a picture. I want to see a picture of this so that if grandma is home and she doesn't take care of him, he has an asthma attack, she gets the right thing. Because, the worst thing we can do is to pull out the steroid with no albuterol and give it to him in an asthma attack. So those kind of kids, I tend to use budesonide. The younger kids, I tend to use budesonide. One of the new kids on the block, as far as EOE treatment, is a pre-mixed version of budesonide that we're starting. That's been approved for ages 11 and up, and we're starting to pull it into clinical practice. It's a nice product in the sense that it's flavored. Kids tolerate it pretty well. But we're working on how we kind of incorporate that in versus doing the older form of the budesonide that we mix ourselves. So that's the topical steroids. Generally speaking, as you'd imagine, when you tell somebody, hey, you're going to be on this is a topical steroid, people hear steroid and immediately that's a red flag. So we always kind of jokingly tell the kid, like, this is not the type of steroid that's going to give you big muscles. And to the families, this is not the type of steroid that's going to make them infertile, because that's always the questions. And we do say, like, these are surprisingly well tolerated. And I typically tell families, look, this is a chronic disease, and the way we think about this has evolved, because what we used to all do is you treat for X amount of time, 3 months, 9 months, whatever it is. Treat somebody, get them better, stop the steroid, and then see what happens. And what always happened is the disease comes back. 95% or more of the time, the disease comes back. And so I think our thinking has evolved a lot to be more like what we think about with asthma, that some people just need chronic steroid therapy because you got to breathe. And in this case, you need to be able to swallow and eat and do all the other things. And my flippant description to the families is I feel a lot better about this now than I did 15 years ago, because we've seen those patients for 15 to 20 years who are doing great on these steroids. It's not to say that they're 100% tolerated, but the steroid side effects are pretty minimal, and probably we stop them for side effects in roughly 10% of patients, maybe maximum. Occasionally we see problems with thrush, or even with esophageal candidiasis, which is certainly a concern. We don't thankfully see a lot of problems with growth. If anything, actually, our data and other people have published the same thing that would say kids that are treated with steroids actually grow a little bit better than the kids that are treated with diet, for sure. So in general, they're pretty well tolerated. So those are your first line options. And so typically we treat with those for 3 months or so. We repeat a scope and say, better, worse, the same. If you're better, then if you're on diet, depending on what kind of diet you're on, we may go down the path of reintroducing foods or not. Typically, you're not able to reintroduce all the foods. Families always ask, can you outgrow this disease? And the honest answer is the vast majority of people don't. Certainly less than 1% of people seem to be able to come off of all their therapies and still be in good control. And even anecdotally, some of my patients who seemingly came off of their therapies or came off their diet and did well have called back later and said, I'm starting to feel it again. if you have failed with those therapies, then it's a question of, do you want to try to combine some of those first-line therapies and do a PPI and a steroid, or a diet and a PPI, or whatever it might be? And lots of patients can respond to those kind of things and those kind of approaches. The new kind of approach that we have, or the new thing that's been approved in the last 3 years. So the last 3 years for EOE is a medication called dupilumab, which is a biologic. So it's a monoclonal antibody that binds to the IL-4 receptor, and it blocks the activity of IL-4 and IL-13. And so it treats a lot of different atopic diseases. And so it's been approved. It was approved first for asthma and eczema, and for allergic rhinitis in adults with polyps. EOE was approved in kids aged 12 and up from 2022. And then it got the approval for down to age 1 in 2024. It's an injectable medicine. So it is a subcutaneous injection, and it's given typically every 1 to 2 weeks. And we'll get into some of the caveats about that in a second. But the dose is age and weight based. It's a little confusing because it is approved for asthma, eczema. Now, it just got approved for chronic urticaria. It's approved for allergic rhinitis in older patients. And the ages for the approvals are different, and the doses are a little bit different. And so the doses can vary. And so where I go off the ranch here again, and this is what we do as opposed to the recommendation, is we will typically try to use a lower dose in our older patients. So the typical dosing is 1 injection once a week. We do a lot of patients with one injection every 2 weeks. And the reason for that in our practice is we saw a lot of patients who got that dose for their asthma or their eczema, where that was the appropriate dose for that, whose EOE went into remission. And so when it was approved for EOE, we just continued with that, and it's worked well for us. And we're working on writing that up now. But the recommendation, just to say that out loud, is weekly dosing for patients 12 and up.
And what do you have to, because we consider this a second-line treatment, especially when we talk about insurance companies and approval, what do you have to fail in order to get this medicine?
So it depends, honestly, on the insurance company. It depends week to week, to be very honest about that.
That's fine.
Because a lot of insurance companies will say you need to fail some therapy. And so if we say, look, they failed diet, they failed PPI, that's sometimes enough. And sometimes they'll say, no, but they have to fail steroids. And then we usually will come back and say, but you wouldn't pay for the steroid. So how are they going to fail that? So why don't you just cut to the chase? I will say the patient, just to kind of think through, as you said, it's typically second line therapy. There are some exceptions to that rule, or there's some times where I would think about it as first line therapy. And so the multiply atopic patient, where they hit multiple indications for dupilumab, I think is a great patient to think about using it early on. And so it's not uncommon for our patients to have eczema, food allergy, allergic rhinitis, asthma. So they're getting topical steroids on their skin, they're getting inhaled steroids for their lungs, they're getting antihistamines, they're getting mast cell stabilizers, they're getting swallowed topical steroids for their esophagus, they might be on a PPI, they're probably on something for an antihistamine for their allergic rhinitis. If I can use one medication that might improve all of those things, then it becomes a much easier sell to say, I really think this is what would improve his quality of life overall the most.
How hard is dupilumab to administer? Do you have to pull them with vials? They come in self-administered pens. Is it pretty easy? And do they just say, do the families just get a box at home that they store in a fridge? How does that look?
So it typically will need to come from a specialty pharmacy. So we do have to tell the families this is not something you just run down to your local drugstore and pick up. We'll have to work with you on figuring out, what's your specialty pharmacy for your insurance company. There's kind of a copay process and all of that we work through with the families. And I am blessed to have an unbelievable MA who handles this and just knows how to navigate this to a degree that's truly astonishing. As far as how it comes as pre-filled either syringes or auto injectors. And so there's no drawing up or measuring of the dose. The dose is the dose, and you just administer the whole thing. It's either subcutaneous injection, so done with a syringe at a 45-degree angle, or an auto injector, which is almost like doing an EpiPen. And again, it's a sub-Q injection. Can be done at home. Just in the interest of being honest about this, it is universally described as being a painful injection. The medication is fairly viscous, and so I think there's a degree of that. There's things that we can do to try to help with that. But it's been interesting the number of patients who've come in and said, "Yeah, I really don't like that shot, but I really, really like the way I feel, so I'm going to go with it." So it has generally been pretty well tolerated. There are described side effects of things like an allergic conjunctivitis kind of picture, or joint pains, occasionally skin rashes, occasionally facial rashes. We thankfully have not seen much in the way of problems with it so far. So it's not that it's our first line medication or that anyone needs to go on it if you're doing well on what you're doing. On the other hand, if someone comes to us and says, I'm really struggling, another reason that we sometimes will do it is he was doing well, or he or she was doing well, they were taking their medicines, or they're staying on their diet, and things were going great. And, they did what all adolescents do, and they fell off the wagon, and it's really hard for them to remember. And now they're in college, and their schedule is different every day. Could we please think about something like Dupixent or dupilumab, because it is much easier, much more likely that they're going to get it in, and they'll be safer that way.
And I was just thinking, we're going to get to kind of complications, long-term pieces, and that type of stuff as we get to wrapping up. But how often are you doing histologic monitoring? That is, like, how often are you repeating biopsies, endoscopies, that type of thing, as we monitor their progression, whether it be better or getting better or worse?
So what we do is we will monitor with any change in therapy. So and typically on a 3-month schedule, there's some exceptions to that. Usually with dupilumab, I wait 4 to 6 months because it does seem to sometimes take a little bit longer to fully take effect. But usually about a 3 months if we're making active changes. Once we get someone into remission, what I typically do, and again, the guidelines differ on this, and people do this based on their clinical practice. So I typically tell families, if you are in remission today on a therapy that you are not changing and you are feeling good, I would like to repeat an endoscopy 1 year from today, and then we can talk about spacing it out from there and go every 2 to 3 years or so. I do tell families I would prefer that we at least look endoscopically at some point on a semi-regular basis, because at least at the moment, and this is very important to say up front, we do not have non-invasive markers that evaluate the status of the esophagus. And symptoms, unfortunately, are not always reliable. And a lot of patients the symptoms tend to be insidious when they come on, so they don't notice that they're having trouble swallowing until something gets stuck. And so we do typically recommend repeat scopes. Part of that's just human nature. Knowing that the test is coming means you're going to study or you're going to take the medicine. Kids can outgrow their doses of meds. All of those things are true. So for right now, at least, we recommend, I typically, in my older kids, will get to every 2 to 3 years or so on scopes if the family wants to do it that way.
So I'm going to put my MedPeds hat on, and I love transitions of chronic care. So as these kids transition to adolescence, to young adulthood, to older adults, like, what does that look like? Do you transition them to an adult GI who will then have similar recommendations? So that means they're just, for the lifetime, they're probably going to get a scope every couple of years regardless? Or is there some place where, like, yeah, you've been stable for like 10 years, we're good to go?
Yep. It's a good question. I think so. One thing I should say is the caveat that I have to everything is I work in a quaternary care center where people are coming to us because of their eosinophilic disease, and so our patient population is probably a little skewed. And so they typically don't want to. They want to go to an adult provider that we recommend to them that has extensive experience with EOE. There are some really spectacular adult eosinophilic disease GI docs out there. There's still a little bit of a element in the community of, well, another way to treat this is I just give you a PPI and then that treats your symptoms, or you feel okay, but eventually you'll get tight. Things will get narrow. You just come to tell me then, and I'll dilate, and then you just come back again when you need to be dilated again. Our argument has always been that may be fine if you're 55 and get dilated every 5 to 10 years. I don't know that that's a great long-term strategy for the 5-year-old that's getting food stuck. And so I would prefer that you go to someone who's going to manage this at least this is an ongoing chronic disease that needs some form of monitoring. Our hope, to your point, our hope is we'll come up with non-invasive markers. Our hope is that we will get to that point of, oh, you've been good for this long. We could certainly space it out. I think if I was treating adults, I would think about spacing it even farther. But we're still treating growing children, so dosing can change. I think this is where some of the less invasive things come in. The transnasal endoscopy or awake endoscopy is a really nice. It sounds maybe certainly more invasive, but what we've found is that our patients that have done it tend to really like it, because we can bring them into the clinic. We do a clinic visit. We numb the nose. We bring them into a room. It takes us 5 minutes to do a transnasal endoscopy. There's no recovery time afterwards. They're out the door. They're eating. They're driving. They're doing all their things. In and out, it's 45 minutes. Clinic visit, scope, and out the door. And we get good biopsies that way. And that's a significantly less time and disruption to your life. So those kind of things are certainly a possibility. There's some newer technologies, just something called an esophageal string test, which is a capsule that you swallow. It's an old test. It was originally a test for looking for small bowel bacterial overgrowth and Giardia. So it's a capsule. It's got a string on it. You attach the end of the string to your cheek. You swallow it. It goes down. The string unfurls as it goes. It actually goes into your small intestine, but you pull after an hour. Now they're able to pull the string back out. You can measure the pH of the string to know how far down the esophagus it went. You elute the fluid that comes off of the esophageal portion of the string, and you look for things like eosinophil proteins. And you can look for other things, some other at the protein level at a relatively easily reproducible clinical test. So that's clinically available now. So it does involve swallowing something, but it's not going to sleep. There are some things that are coming. So hopefully better ways to do it.
That's incredible. I think I saw a magician do that on stage once.
It's I back in my dim and distant past, my mentor in fellowship was the one that developed that test, and so I've had it done many times, and it's
wow.
It is another thing. I've had transnasal scopes done on me many times at this point as well, and so I can kind of say the string is definitely another option. So. Different people tolerate different things better, though.
All right. Well, we want to get into the up and coming and kind of the things that you see on the horizon for EOE. But before we do that, I just wanted to take a quick step back and just kind of round out our discussion in regards to the treatments. One thing that we did not talk about was the role of systemic steroids. This may be a very quick answer on your part, but is there any role of systemic steroids in EOE?
Yes, rarely, and less as time has gone on. So people used to do it more commonly, and we will still, if someone comes into the hospital with a food impaction and has terrible dysphagia, and even after the food's removed, they're still miserable. There's some thought like I'm going to give them a jump start by giving them, a 5-day burst of oral steroids or systemic steroids. If I do it once a year, that's probably a big year for me. And so it's not that it's unheard of. It's not that it's the wrong thing to do, but it's absolutely not long-term therapy. So we very rarely do it. And usually we're able to get people under pretty good control pretty quickly with any of the options that we've talked about. Yeah, and again, I think the addition of dupilumab into what we can do is something that has changed what we do, because there's been published papers looking at dupilumab even in advanced disease, so people with fibrostenotic changes on their esophagus, with really good results. So even in that very severe patient population, it's not to say if they're miserable, maybe you do something like a few days of steroids but start them quickly on something like dupilumab, rather than kind of go stepwise. I think we didn't necessarily talk about complications. We've been kind of
I was actually hoping to check, because as you just mentioned about fibrostenotic disease, I was just going to say before we got to the end, can we just kind of walk through how bad can this get if people present late, for example, or if they don't take their medicines and have a tough time showing up to clinic for whatever it may be? Where can people get? What complications should we know about? But the good news is it sounds like dupilumab might be our answer no matter what.
Yeah, there's good options if we can get to you. And I tell families, and again, this is in the interest of being as transparent as possible with families. The question is always, well, okay, he's not that bad. Chronic therapy, being on medications for you're telling me you can't tell me how long, but it really sounds like the rest of his life. What's the worst that could happen? This isn't that bad. This is just bothering him a little bit. So we try to tell people, like, I don't have a crystal ball. And the honest answer is there are some people, we know this from autopsy studies, that go to their grave with an esophagus that has a ton of eosinophils and probably even looked bad. And you can talk to the families and they'd say, well, he had a little bit of reflux, but otherwise he was fine. So those people exist. For me as a pediatrician, it's much harder for me to say, well, if your child it's easier for me to say, well, if your child of 5 or 6 is choking on food, it's very unlikely that they're going to be able to go, that is not going to progress. There's good data from some older studies showing that patients with longer duration from symptom onset to diagnosis or symptom onset to kind of getting under therapy, the longer you have untreated disease, the higher the risk of fibrostenotic disease is. And so that typically we think of that as forming a stricture. I think that is certainly probably the most obvious thing. I think there's, and so food getting stuck, needing to get removed endoscopically. There's other things that can happen that can also lead to dysphagia. So if you develop motility abnormalities, the muscle function isn't as effective. Due to inflammation, that's certainly a possibility, and that may also be because the esophagus is sort of stiff. One of the new concepts in EOE is thinking about distensibility, and so the way I describe it to families is, you think about like that, that the snake that swallowed the deer, right, where it swells, and if your esophagus is getting, even if it's normal caliber, when we look with a scope, it looks like it's fine. But if it doesn't stretch when a big bolus of food goes down, then functionally you're going to act like you have a stricture. And we know there's a technology called functional impedance planimetry, or that is the endoflip device. That is a balloon that you expand so you can control the amount of pressure that it applies. And so we have sort of standards to say how well should the esophagus distend. And we can see in some of these patients with EOE is you have to put a lot of pressure, or it just doesn't get very big when you get to max pressure. So it's, you get higher stiffness. That's the biggest feared complication is any of those things leading to dysphagia and food impaction. On the good news side, it does not appear to be a pre-malignant condition. And so, there's some scattered case reports out there of people who have developed Barrett's and those kind of issues, but it's more likely that was due to some concomitant reflux and, the other adult things that drive you to get Barrett's. It does not seem to be something that progresses to cancer. As eosinophilic esophagitis is a pure disease, does not seem to progress to cancer.
And then it sounds like if you do have fibrostenotic changes there, we would still try to get our biologic therapy or whatever we could get back from that medicine standpoint. You also had mentioned a little bit about dilation. Is that what you have to do anatomically? Just once you have strictures there, you just got to dilate it up until you can get food that passes?
Typically, yes. And so the dogma for most of us is it can be very difficult to tell what's a fixed sort of fibrotic stricture versus what's just edema and inflammation. And so if on your initial presentation, even if it's food impaction, unless it's a pinpoint esophagus, we typically don't dilate on that initial scope. We typically will try to treat with whatever it might be, whether that's dupilumab, whether that's steroid or any of the therapies, and see, because sometimes we go back and we don't actually need to dilate. And dilation is not pleasant. People will describe it as being stabbed. It does hurt because you do need to actually you need to cause a tissue rent in order to know that you've actually broken through the stricture. So it's not something, we used to really worry about this disease because of this fibrosis, and there's some early descriptions of perforations with dilations for EOE, and there's a lot of concern over, is this a disease with a higher risk of perforation? And if you're cautious about it, the answer is probably not. You don't go 0 to 60. So you go, sometimes for kids or adults who have eosinophilic esophagitis strictures, we tell them, yes, we're going to have to dilate you, and it's probably going to be a few sessions. We don't want to go from a small esophagus to a normal caliber in one session because the risk goes up.
And then just kind of the last piece in there, is there any role for surgery when it comes to resection or anything along those lines?
Vanishingly rarely. I can't imagine. I cannot think of a patient that I've ever had unless they've had some other concomitant issue. Patients who've had esophageal atresia who develop EOE, and then they stricture at the repair site and it becomes a real problem. Something like that. You might do surgery, not resection. I've never heard or seen of a patient who's had an esophageal resection or any sort of bypass, thing for that indication.
Well, I'm glad this is not a surgical disease process, because we need as many medical disease processes as we can as a group of pediatricians here too.
Well, and one thing to say is, there are descriptions, and this is another reason that people realize this is something other than just reflux. So there are descriptions of people getting Nissens or fundoplications before people kind of teased out that this may be a different disease process, and realizing, oh, this actually didn't help and may have made things worse because now I've given them another set of complications.
It's honestly, it's been a fantastic night. I mean, I learned so much, and I really feel like, there's been so many things that have changed with EOE over the last couple of years that I'm really happy to have been able to talk to you. We are all happy to have been able to talk to you tonight to get all these updates and understanding this so much better. Can you give us a couple lasting take-home points you want our listeners to leave this episode with?
Maybe I'll lead with that first point, which is, this is really an exciting time in these diseases. I think our understanding of eosinophilic esophagitis has come forward light years, and it's really accelerated in the last, let's say 5 years. There are some other new treatments potentially on the horizon. There are some less invasive monitoring things that are hopefully coming. As we talked about, transnasal endoscopy is a technology that is really kind of exciting. The string, some of these other things. So, things are much better. I practice very differently now than I did when I started, and certainly, my senior partners can tell us, this is something that we used to think of as this incredibly rare disease, and we'd all kind of cluster around like, oh, you never believe what I saw. It's a routine disease now, and so this is an increasingly common disease. I would say one thing I try to. We talked about this earlier, but I really try to emphasize this to families and to pediatricians or whoever else. Yes, this is a chronic disease, but it's a manageable disease. And people, guaranteed, lots of people who have this disease, and you have absolutely no idea. And that should be the goal. So this is not life-limiting. It shouldn't be life-limiting. It shouldn't be, you should still be able to achieve all the things you were going to achieve before you had this disease, but it is the start of this is a relationship that we've just developed, right? This is not I give you a medicine and send you away kind of disease. So those are maybe my kind of big take homes. So hope for the future. this is a chronic disease, but it's treatable, and we can make this better. You don't have to live like this.
I love it. And before we sign off, is there anything you want to plug? Anything you want our listeners to check out before we sign off?
Since I think we're going to be catching hopefully a bunch of residents here, I would just want to plug pediatric GI as a specialty. So I'll do that. I'll make NASPGHAN, which is our Pediatric GI Society, proud, and I'll plug NASPGHAN as well as the greatest of all professional societies. But for those of you who are thinking about what you want to do with your life, for those of us who do Peds GI, like you get it all, right? We get acute care, inpatient care, outpatient care. I get to see patients that I've been managing for a decade or more and see them grow up. I get to take care of acute issues, either with EOE and food impactions, or dilations, or foreign bodies in the middle of the night. I get to do. I do a mix of some research, some administrative, some clinical care. I think you can tailor your specialty to what you want to do. And for those of you who are proceduralists, it's a great way to do, you get to do procedures too. And so that's my plug. Go be Peds GIs. Come and talk to me when you're done with it, because we're hiring.
Well, thank you so much. I had a great time. Everyone did too.
Absolutely.
We should have you back on sometime to do some other topics.
I'd be happy to.
This has been another episode of the Cribsiders.
It's for the
kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value, practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producers for this episode, Drs. Rachel Holloway and Dr. Jennifer Chisholm, and our wonderful social media team on X, Instagram, and Blue Sky. I've been Sam Mazer.
I've been Rachel Holloway.
And this has been Chris the Chew Man Chew. Thank you, and good night. And if you made it to the end, I actually do have an AI poem. I literally just ran it, and I haven't read it yet, so we're going to try this out. The title is When Food Becomes the Enemy. Swallow should be simple, swift, and clean, but eosinophils gather thick between the layers of the esophagus wall, making every bite a painful crawl. From milk to eggs to wheat and more, foods once loved now hurt and sore. Reflux medicines fail to heal this different kind of burning meal. Through scopes we see the furrowed lines, white plaques and rings that food defines as foreign foe, not welcome guest, in airways meant for swallowing's rest. Elimination diets guide the way. Remove the six, then foods replay, one by one to find the cause of this inflammatory clause. Inflammatory clause. Or topical steroids swallowed down can calm the angry and swollen crown of tissue that has lost its way and help the healing start today. From infants who refuse to eat to teens whose meal are bittersweet, EOE demands our careful art to mend each tiny hurting heart. It's not too bad.